I'm Daniel Levine, and this is the Bio Report.
Existing anticoagulants can prevent life-threatening blood clots for people with cardiovascular and metabolic diseases. The problem is that because of their mechanism of action, they also work to suppress the body's ability to stop bleeding as it should. As a result, these therapies can be underutilized by patients who need them. Anthos Therapeutics is developing an experimental monoclonal antibody that can suppress coagulation without disrupting hemostasis, the biological process of stopping bleeding. We spoke to John Glasspool, CEO of Anthos, about the problems of existing anticoagulants, the novel target its monoclonal antibody works on, and how it's able to uncouple the pathways for thrombosis and hemostasis. John, thanks for joining us.
Danny, it's my pleasure. Thanks for the invitation. I'm looking forward to the call.
We're going to talk about Anthos Therapeutics, its experimental next-generation anticoagulant in development, and why it's needed. Let's begin with the problem of heart attack and stroke caused by cardiovascular and metabolic disease. How significant a problem does this represent today?
Well, what we know from epidemiology studies, Danny, is this is, those diseases are going to cause 1 in 4 Americans' death. And obviously, it's, the biggest risk factor for those diseases is age. And unfortunately, with the exception of the COVID period, we're in a period where we're all aging and society's aging. So it is still the number one killer in terms of Americans today.
Before we talk about anticoagulants, can you explain the difference between hemostasis and thrombosis and how the two are linked?
Yeah, that's a great question. And the way we say it, Danny, is physiological hemostasis. So hemostasis that the body's got there for good logical reasons to protect you, when you have a cut or when you have some trauma in order to naturally protect you. So, of course, you cut yourself, you start to bleed, you clot, the clot forms, and then you start to heal. When we come on to thrombosis, then we talk about pathological thrombosis. And obviously that is the body clotting, but not in a way that's naturally good for you and beneficial for you. And so the thrombus is what leads to those issues such as a stroke or a myocardial infarction we talked about at the beginning. So what we're trying to do is protect you from a thrombus whilst keeping your hemostatic system intact.
How targeted are existing approaches today to anticoagulants?
Well, what we've seen is a key improvement in terms of the DOACs versus warfarin. So there was some improvement, but essentially all of the current agents work in the common system. And essentially, they do protect you from thrombosis. And anybody that's out there, obviously, please stay on your medication. That's the best thing to do to protect you from thrombus. But equally, unfortunately, they do cause bleeding. So they do interfere with that normal hemostasis. And so you see an increasing bleeding. Some of it, serious, but, much of it also a nuisance bleed, such as bruising, which leads people to feel less confident in their medications, thinking it could lead to a larger bleed and causes a lot of discontinuation. And with the current agents of people bleeding, about 30% of people remain untreated. So there's a significant need to protect people within this current paradigm.
So there are plenty of people using anticoagulants like warfarin or coumarin or heparin. What's the biological mechanism of action here with those anticoagulants?
So what they're doing is they're into predominantly, and we'll talk about the newer ones. They're predominantly interfering, if you will, in the common pathway around factor 10, and factor 10 is involved in normal hemostasis and in the protection of thrombosis. And that's the issue, that they do protect you from clots, and yet they do increase that level of bleeding just by the fact they're interfering with your normal hemostatic system.
I understand there are issues with those anticoagulants, but there's concern about them being underutilized. Is it that they're underdosed, that patients don't comply because they're fearful of them, or doctors don't prescribe them as aggressively as they should?
Danny, you're very well informed. In fact, all of the above. People, are worried about the bleed risk. So some of them don't adhere. Clinicians worry about some of their more fragile patients, and so they think the risk of omission is less than the risk of commission, as in they're worried more about the bleeding in that individual than about the event. And because of the bleeding, and because of potentially, say for example, daily injections on one of the treatments, then people also don't adhere. And this is why we believe 30% of people are untreated and many other people are undertreated.
I know there was a recent study that suggests bleeding rates in the real world in atrial fibrillation patients using anticoagulants was higher than in clinical trials. What did that study find, and what's the significance of that?
Well, I think, the key factor that we know, of course, is that, you get a very defined population in a clinical trial. There's many risk factors that they don't have, such as, they tend to have better kidney function, they tend to be younger, they tend to be not on antiplatelets due to the control of the trial. And what we know is once you get into the real world, unfortunately, what we see is, that the bleed rate from the clinical trial is almost the lowest you're going to see. And what we see is once you're in the real world, you see that increase in the rate of bleeding.
Does that suggest that physicians are working under a misunderstanding of how significant the problem might be?
No, I think the real world data probably gives you a bigger explanation of why people are untreated. So if we look at the controlled trials, for example, people will argue that only, 3 to 4% of people have a major bleed in the trials. And one might say, well, that seems quite low. But when you look at the total bleeding, even in the controlled trials, you're at 18% with any kind of bleeding. And of course, we all have grown up with to say that bleeding is not natural, right? We're trying to not bleed. And so when we see bleeding in any place, then it's not natural. And that, we think, undermines all therapy. And of course, once you're in that real world setting that we just discussed, that in fact the bleeding is more prevalent than the controlled trials due to the opposite of the clinical trial criteria. So patients are older, they're more likely to be on an antiplatelet, they have some degree of renal impairment, they have some degree of liver impairment, and all of a sudden the bleed rate, once you're exposed to that wider population, we think, based on that work, that inevitably that bleed rate goes up. So physicians and patients get more exposed to bleeding than the controlled clinical trials would suggest with the current agents.
Your lead program is abelacimab. This is an experimental monoclonal antibody. How does it work?
So as you say, the drug is experimental. What we know from the pharmacology is how the drug works is the following. It acts in a different part of the bleeding and clotting cascade. It acts on factor 11. It does two things. It's got a dual activity in that it inhibits factor 11, the zymogen, as well as the activated factor 11. And so we know, and we had a study published in the New England Journal of Medicine in July last year, that it's very effective at stopping clots. We know that from that study because we saw a greater than 80% improvement over the current standard of care in reducing clots. what we believe is advantage, and we need to, of course, prove this in controlled clinical studies, is the fact that factor 11 can pharmacologically uncouple hemostasis and bleeding. So by inhibiting that factor rather than factor 10, we can leave your normal hemostasis system intact, not increasing bleeding, and yet protect you from the pathological thrombosis. And that's what we hope to prove in our ongoing clinical trials.
There are a number of experimental therapies in development seeking to target factor 11. The fact that your antibody can target both factor 11 and the activated form, is that a point of distinction for you?
Well, first of all, Danny, we're very happy that many companies see the potential benefit of factor 11. We think that supports our hypothesis that this is going to be a paradigm shift within the protection of people from thrombosis. So we're really happy to see other molecules in development. We're the only one at this stage that we're aware of has a dual activity in inhibiting both the factor 11 as well as the activated form of factor 11. Obviously, this is a hypothesis at this stage, but we believe that by inhibiting both 11 and 11A, we can bring about more profound suppression of factor 11. So a greater suppression of factor 11, which we believe can convey into a more effective agent in terms of preventing clots. We see that appears to be the case in cross-study comparisons, but that's why we believe that dual activity may be beneficial, and we hope to prove that hypothesis in further clinical trials.
What's known about the antibody from studies that have been done to date?
What we know about from studies that have been done to date are it can reduce essentially can reduce your factor 11 markedly. So we can essentially bring about almost 100% suppression in your factor 11 with the higher dose. We know that it doesn't cause any dose-related increase in bleeding. So we know that. And we know that it's very, very effective at protecting you from a clot. So we already know a great deal about this drug and how it behaves. And now we're in larger phase 3 trials. We'll obviously hope to go on and prove the overall profile based on this hypothesis that factor 11 can give you protection without increasing your bleeding pharmacologically.
The phase 2 study compared it against standard of care. How did it compare both in terms of efficacy and safety?
So the study is very much, the proof of concept, which is a TKA model. So you're undergoing an operation, and then on a readout called venography, you're looking at the development of clots on that venogram. We were comparable in safety. Obviously, the study is very short, so it's a 10 to 12 day readout, but comparable in safety. So no real difference in safety. Not that we would expect to see any differences in safety in that length of study, but most importantly, it had a greater than 80% reduction on the development of those clots on venography. So really supporting the fact that at that point in time, that this drug is inhibiting the development of clots very effectively compared with well-established standard of care.
And what is the trial design for the phase 3? How big a study are you doing, and what are the endpoints you're using?
So the phase 3 program is in cancer-associated thrombosis. And so what happens in this situation is you're undergoing, you've developed cancer and you present with a clot, and obviously you intervene at that point in time with abelacimab. And obviously our study is 2 different trials because we have 2 different comparators. One study is versus low molecular weight heparin, and the other study is versus a DOAC. The reason that one of the comparators is low molecular weight heparin is because patients with GI or GU cancer have a higher bleed rate, and the recommended treatment is low molecular weight heparin. So in that study, that's the comparator. In the other study, which is all other cancer types, it's a DOAC. The 2 studies combined are over 2,200 patients. And obviously the endpoint is resolution of the clot in comparison with the comparator. So we're looking for both efficacy and safety in those studies.
There's a broad set of patients who can benefit from anticoagulants. How are you determining what indications to go for?
We're, as you say, there are many places where people run the risk of developing a clot. The way that we've looked at the market is to look at where is there a significant unmet need, where we think that this product will encourage clinicians to treat more patients. So, for example, our starting indication of cancer-associated thrombosis, everybody gets treated or should be treated, but no one has actually got an FDA indication for that treatment. And so this is an area where we've recognized we think people would get treated more effectively and for longer to give them that protection if somebody developed an FDA-approved drug. And so that's why we've started in that indication. Our next indication is we're looking at places where patients are untreated for a number of reasons, so we can bring our therapy to make sure physicians feel comfortable giving people the benefit of anticoagulation, and so get more people treated in the future.
And are you going to have to pursue this on an indication by indication basis, or is there a broader label you think you might be able to pursue?
We think in this particular space, most people would anticipate that we would need an indication by indication process. In some disease areas, such as pain, you can go for 3 different pain types in order to get a broad indication. Given the relative differences in risk in terms of the development of clot and the risk of bleeding, we think this is more likely need to be an indication by indication disease area.
And how's the company financed here, and how far will existing funding take you?
So we were formed, Anthos Therapeutics was formed by an agreement between Blackstone and Novartis. So Blackstone, a private equity company, are our financial backers. And our current funding will see us through to the end of the phase 3 clinical trials.
And do you expect to commercialize the drug on your own?
We think the cancer thrombosis area is a very manageable indication for a small company. So we think we can commercialize that ourselves in the United States with partners ex-US. And we think as we get into the larger indications, then we would seek a commercial partner to help that commercialization process.
John Glasspool, CEO of Anthos Therapeutics. John, thanks so much for your time today.
Danny, I appreciate you taking the time, and I just want to close by thanking you, but also thanking all the physicians and patients who are enrolling patients in our clinical trials. That's the only way that we develop new science, and we very much appreciate their support.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.